Good evening, friends. Today we are going to have a wonderful CME on lung transplantation. I think we haven't talked about this subject. Lung transplantation is special because lungs are not available and only the live donor transplant is not done. It is only after the brain death or the trauma of patients whose lungs are donated. And it is not like kidney, that you just place the kidney, any kidney. You have to match the lung size to the thoracic cavity. There are a lot more things. Then the lungs are directly exposed to the environment, so they are at risk of a lot of infections. Problem of rejection is there. About 80% people are alive by 1 year, those who are operated, and at 50% are alive at 5 years. But there are patients who have lived for more than 10 years in lung transplant. It is more prevalent in South because there is a culture of organ donation. We will be hearing a lot about this from Dr. Rahul, and Dr. Rahul will be introducing his department and giving opening remarks. He is a director, chairman of pulmonology, sleep, lung transplant at Max Smart Hospital. Dr. Rahul Sharma.
Good evening, ladies and gentlemen. So, before starting this, I think I must confess this that I am already very high. Not because of the tonic that is available here, but because of the energy and enthusiasm that I am seeing here. Thank you very much everyone for joining this CME and present here. So, I will be briefly talking about what we are doing at Max Smart.
छोटे छोटे टुकड़ों में हो जाएगी काट लेगा इधर की वजह लाइट उधर की जला दे रहा इसके ऊपर स्पीकर के ऊपर
So before starting this topic of interventional pulmonology or missing limb, I must introduce all of you to my team. So unfortunately, Apar Jindal, who is the director of transplant and the transplant physician, is not there because his mother is not well today. But he is the man behind, collecting this team of and making this holistic approach. I am Dr. Rahul Sharma. I am heading the pulmonology and critical department, critical care department. Dr. Saranya is our cardiac anesthetist, who will be looking after our critical care patient as well as helping us in, managing our lung transplant in post-transplant care. Dr. Kamran is also not here because of the surgery that is going on in Max Smart. Dr. Prem John is our best man. He is the thoracic surgeon who is being associated with transplant, I think, since the time it has been started in India. Right, so we are very, very privileged to have this team with us. Dr. Anmol is the junior most, but he is the star of our team and he is doing a lot of good work for us, and he is a very bright student, I must say, and he has joined us recently also. Dr. Nazia is also there. She is also a thoracic surgeon and she is busy with Dr. Kamran for the surgery. So this is all about this, and as I have already met every one of you personally, the basic concept behind making this team is moving.
थोड़ा टाइम ले
So the basic idea of starting this team, which is probably the unique thing in India, that we are starting on giving a holistic care in lung patients, for the lung patients or people who are suffering from lung disease, and along with this we are also having specialized center dedicated for sleep evaluation and sleep related problems, and the main focus is on sleep apneas and insomnias. So now I start my presentation, and when I talk about my practice, what I look after in this department, I look after majorly 4 pillars. Most or almost all the respiratory diseases, intervention pulmonology, critical care with my team of critical care who is headed by Dr. Saranya, and the sleep medicine. So these are the basic 4 things that we talked about or we see in our day-to-day practice. So I'll be starting with our midway things, not from the basic things or not from the advanced thing. I'll be starting with the intervention pulmonology, why it is important and what is the missing link. Right. So we all know, we all had learned about the anatomy and the physiology of lung. So we have lung parenchyma and the lung nodes. So nodes are around the trachea as well as into the peripheral part of the lung. And the disease which can be there in the lung itself, in the trachea, lymph node, maybe a nodule in the lung, or a picture like ILD that we are seeing, and we have established the program mainly for COPD and ILD for lung transplant. And when we talk about the paraphernalias or the armamentarium that I have to diagnose and treat these diseases in terms of intervention pulmonology, these are the things which is there, and we have everything in our department. Flexible bronchoscopy, rigid bronchoscopy, stenting which can be metallic or silicone, endobronchial ultrasound or EBUS, bronchial thermoplasty, although we have this, but nowadays it is no more advocated for bronchial asthma patient. Cryobiopsies, which is again a boom as far as the diagnostic and intervention pulmonology is concerned. Navigational bronchoscopy to reach that peripheral nodule to a success rate of 100% almost, and medical thoracoscopy. So why I choose a title of missing link? Because most of us think that a clinical history and a radiology is enough to make almost all the diagnosis. So I'll start with this case. 67-year-old male, never smoker, with uncontrolled diabetes, presented with shortness of breath, non-productive cough, fever. When the patient came to us, it was around 17 years, more than 17 days. Patient was on oral and IV antibiotics without any response. His TLC was normal, MON2 was 10. And even after non-response to therapy, patient was started on ATD, considering that this is the upper zone of the X-ray. Patient is not responding to the fever, patient is diabetic, which is a common thing that all of us think as first diagnosis. But unfortunately, patient developed drug-induced hepatitis and landed up to us. So on admission, patient has normal TLC, blood sugar was little high, HbA1c was uncontrolled, he has high CRP, D-dimer, fever profile we did was negative, blood urine culture was also negative, and galactoman we did for aspergillus was also negative. So then we did the CT of the patient. So I think I will stop CT at the time at abnormality. So this was the abnormality. We can all see that there is a consolidation with some sparing in the middle part of the lung, which is in radiology is called Atoll sign. So we think about fungal infection in this patient. We went and did the bronchoscopy in this patient, and it was found to have mucormycosis. So these are broad ribbon-like structures, irregular with poorly defined absent septation and non-uniform branching. Patient was started on antifungal. And he did show good response to the therapy, and the opacity almost cleared up. Right. So this was the previous X-ray, and this is the new X-ray, and the patient is improving well. So this is one of the messages that I want to convey, that not everything you see in the upper lobe of the lung, persistent fever, diabetes is not tuberculosis. And there is the thing where comes the role of intervention pulmonology. When we go about TB, guidelines or the National Tuberculosis Program, they also say that no radiological pattern is diagnostic of tuberculosis. Right? So fiber optic bronchoscopy facilitate rapid diagnosis, add value to detecting MDR cases, prevent delaying the management, and additional advantage of diagnosing several other conditions which mimics tuberculosis. So all effort should be done to confirm TB microbiologically. This is the time when guidelines also says that you should not start patient clinically on anti-tubercular treatment. And this is a very important paper where they try to look into 286 patients suspected tuberculosis bronchoscopy and valve, and they found that 21% of the patient has alternative diagnosis. So that is very, very important. When we see a patient and we believe or we, clinically suspect that this is tuberculosis, we must confirm it microbiologically. And there are some prevalent tests in the society or in the clinical scenario that we see. MON2 test, IGRA or TB Gold, and PCR based tests. So I'll be talking about this. So MON2 test is for the identification of infection. It never confirms disease. There is a difference between infection and disease. So it just shows that the prevalence of infection in our society is this much. So it has no role in confirmation of diagnosis of TB. IGRA, TB Gold, also it detects tubercular infection in low prevalent countries. So it is mainly made for countries where TB is not that prevalent. And role in India is not very clear. We utilize this test to exclude tuberculosis in patients whom we are suspecting and confirming sarcoidosis. So it has again no role in diagnosing of TB. Then PCR based serological test has been banned in India in 2012, but still being prevalent in most of the labs. Next case. Again, a very common case that we routinely see in practice. Recurrent pneumonia. This was a 68-year-old male, former smoker, chronic alcoholic, history of recurrent pneumonia on the same side, left side. Treated with antibiotic, multiple centers, 7 hospitalization, 5 in ICU, once he was intubated with low FEV1. So we all presume that the patient has low lung function, patient is prone to get infection. This was not done at our center, this was the outside CT which we tried to evaluate that why the patient is having pneumonia on the same side. And I think this is the clue that we found, that there is some narrowing in the airways in the upper lobe. And then we go ahead and do the bronchoscopy of this patient. So there was a narrowing in that place, and that is probably the reason that patient was having pooling of the secretion and recurrent pneumonia. We went ahead and did the bronchoscopy and stenting in this patient, and the patient is doing very fine. Case 3. Again, so I'm just highlighting the role of intervention pulmonology here, where what we think and what it can come out. So this is a patient, we always see this rat tail appearance, CA esophagus. So this patient has esophageal carcinoma, operated more than 3 years back. Esophageal stenting was done for tumor recurrence 2 months back. Patient is coming up with choking and coughing sensation and not able to eat after 20 days. So this was the stent which was already placed in the esophagus of the patient. But the guidelines usually say whenever you put a esophageal stent in your patient of CA esophagus, you must protect the airways. And this was not done in this patient. So this patient has recurrent aspiration and pneumonias. We did the bronchoscopy of this patient also. And this bulging you can see in this, this is the stent bulging that you see, and there is a perforation in the posterior wall of the trachea. And the patient was aspirating because of this. So this patient was put in a stent, Y stent we put in this patient. So this we did for as a palliative measure. So because of the aspiration, patient was not able to eat and was having recurrent pneumonia. We just put a Y stent in this patient so that we can palliate the patient and give some good life to the patient. So this was the stent which covered the posterior wall of the trachea so that there should be no aspiration, and this was the Y stent that we put in. Right. So this was the stent that we did in this patient. Other than this, we have rigid bronchoscopy also. Rigid bronchoscopy mainly we utilize in patient who has endobronchial tumors, complete obstruction, or in cases of difficult airways where we feel that the chances of desaturation is more. So we are doing rigid bronchoscopy also in these patients. I think this is again a very important patient that we need to understand, that this patient was treated as miliary tuberculosis on the basis of X-ray, shortness of breath, dry cough, weight loss for last 2 months. The patient was only 36-year-old. She took ATT for 3 months without any relief. Bronchoscopy was also done. It was negative for infection and tuberculosis. But before bronchoscopy, nobody has evaluated the pattern of CT picture in this patient. So this is a pattern which is mainly fitting into either organizing pneumonia, PAP pattern, or some kind of rare ILDs. We again did the bronchoscopy in this patient. We wedged the scope and try aspirating the fluid from the same segment again and again. and there was this milky fluid which has come out. This patient was having a pulmonary alveolar proteinosis. We did a therapeutic lavage in this patient, and I think, I'm not very sure, I think 14 liter of fluid was instilled and taken out for the clearance of this, and after that the patient got relieved in the picture, but most of the time these patients require repeated bronchoalveolar lavage. So this was it, and this is again a very important patient. You know, COPD patient coughing every day. This patient come to us coughing. We did see the X-ray of the patient. It was very bad. Lung function was very low. Patient has streaking noctuses also. Persistent cough for the 1 month. Anyone can highlight what is the abnormality in this X-ray. So I will give you a previous X-ray also. This was the previous X-ray, around a year-old X-ray. So we again feel that it is almost the same. We started the patient on treatment. Again repeated the X-ray. It is almost the same. But there was one thing which was not there in this opacity. Right. So we did bronchoscopy of this patient. Anyone can guess what it is? Tooth cap. So this was a tooth cap that came out from the lung of the patient, which was aspirated by the patient during cough or with some reasons. And since we were already made our mind that this patient has COPD and patient is bound to cough, we were just treating this patient on the line of COPD acute exacerbation. So we have all these paraphernalias also to take out. Sir was asking about pediatric bronchoscopy. We did pediatric bronchoscopy recently in a patient who had a almond piece in their lung, and the only sign that this patient had when the patient was crying, they have these. Otherwise, patient was absolutely normal. Right. The other important intervention pulmonology, and I think it is gaining popularity like anything, and it has made pulmonology, it has also given some popularity to pulmonologists also, is the endobronchial nodal aspiration or the EBUS TPNA. So when we see lymph node in our lung, the conventional way of taking out this lung was doing a CT scan needle till the mediastinum and taking it out, or mediastinoscopy. But since the invention of EBUS in 2012, I think scenario has changed a lot. So we can do all kind of staging and lymph node assessment with this scope. The scope has a small ultrasound at the tip of bronchoscope, so we can just put it along the trachea and see the structure around. Right. So why this is important? Because this patient was again very precious. 14-year-old male student, losing weight like anything, dry cough, Montu 2 mm. The CT was very characteristic. The patient has necrotizing lymph nodes. So everyone says that it is a tuberculosis. Let's start treatment. So we also think of the same, but our pediatrician friend says that no, you must confirm this. So we were also very skeptical in doing interventions in the pediatric population, but they said that no, you need to do this because patient is having fever. It came out to be TB, but the only unfortunate part was that it was rifampicin resistance. So when we look into the literature, 17% of the tuberculosis, whether it is the first time, 17% of these patients can still have MDR or drug resistance TB. So that is again very, very important that you should or you must confirm your tuberculosis diagnosis by microbiological information. Right. The guidelines again says the same thing, that even for extrapulmonary tuberculosis, you must access to tissue-based diagnosis in these patients. Right. Other than this, we are running a full-fledged sleep clinic with all kind of problem related to sleep, whether it is insomnia, obstructive sleep apnea, central sleep apnea, other sleep disorder breathing, PAP device titration, and polysomnography. And we also have a very dedicated pulmonary rehabilitation department, because none of the transplant program can run without pulmonary rehabilitation, whether it is pre-transplant or post-transplant. So we have dedicated team of physiotherapists also who is doing in-house as well as tele-pulmonary rehabilitation to all our patients. We try to publish all the rare cases to this. So this is the first case in the world that we did endobronchial guided pericardial tapping in our patient who was refused by our cardiologist friend because the pericardial fluid was on the posterior. So this was the first case in the world that we published. Then we have mucormycosis cases in which we try to take out the sample because the chances of bleeding is very high. So again we utilize our EBUS. Then EBUS related mediastinal mass. diagnosing lymphomas are very, very difficult with your FNAC samples or the cytology. So what we have now doing, we are now doing that we are taking a biopsy from the lymph node by applying a cryoprobe through the ubus, which is again 1.1 mm, but it solves the problem of misdiagnosis, because most of the time when you take FNAC even from outside, it is negative. So that is all in terms of intervention pulmonology. If you want a break, I can take a break. Otherwise, I can continue with my basic pulmonology. Then Dr. John will talk about lung transplant. So should I continue with this?
Okay, Dr. Rahul, as Dr. Rashid has asked you to intervene at this juncture. You have a wide range of pulmonology practice as it is being done nowadays. We will have to break at this stage and we'll ask the surgeon to now come and enlighten us about lung transplantation. Dr. P, because the entire audience is willing to listen to about the lung transplantation and how it has been progressing in the city of Delhi. And whatever question and answers are there, will be after the end of all the speakers' talks. Dr. P, thank you. As per the information given to me, Dr. Prem is a senior cardiothoracic surgeon who is specially practicing lung transplantation. Now, I'm also a thoracic surgeon, just for clarifying the present audience. Lung transplantation is a lot of cardiac surgery because it involves three anastomosis. One between the left atrium and the venous chamber, one between the pulmonary artery and one between bronchus. So a lot of cardiac surgeons who are very familiar with putting the patient on cardiopulmonary bypass and occasionally doing an anastomosis are much better transplant surgeons than thoracic surgeons. Because thoracic surgeons in India are dealing with tuberculosis and destroyed lungs and malignancy and other things. So that's why Dr. Prem, with a lot of experience of cardiac surgery, is specially dedicating himself to lung transplantation, which is still in nascent stage in India. As far as I understand, he has much larger number in the south, and because he has shifted to the north India, we are hoping that lung transplantation as a modality takes foothold in the city, in northern city, especially in the city of Delhi NCR, as well as other northern India. Over to you, Dr. Thank you.
Thank you for this wonderful introduction, sir. And first of all, it feels like a blessing, and I'm very excited to be in such a elite crowd. And the camaraderie that is exhibited is very warm, inviting, and very inspiring. And thank you, Mr. President, sir, for the wonderful introduction. You took us to all the tables there, and personal introduction. And I was told to keep this as a very interactive slide, so we didn't make much of a topic here, so I'll just go through it. So this is, I'm myself, Dr. P K Mangla. So I've taken up the position of Director of CPS and Heart and Transplantation and Mechanical Surgery Support at Max Smart Super Specialty Hospital, Saket, as well as Max Nano in Mumbai. And like Dr. Rahul has graciously introduced ourselves. My main right hand is Dr. Shania, he's a cardiac anesthetist and the pillar of ICU. So this is my background. So what the world sees in us is what the home gave us and what we are. And I'm privileged to come from a great institution. St. John's did my basic undergrad training as well as general surgery training, and then went on to do my cardiothoracic training from Madras Medical College. And then subsequently I worked in government setup for 2 years, and then joined the corporate world. And I had this invaluable mentorship with Dr. Sandeep Adawar, whom I was associated with our performed lung transplants. And then we grew wings, and then we came out, and me, myself, Sharanya, and then we came down to Chennai, and then we did about 50 transplants in the first year, the first 2 years, and then about 50 transplants. So this is our expertise. We do general cardiac surgeries, cover up all the CABVs, myocardial patient, all the general cardiac surgeries and complex cardiac surgeries. And on top of it, our main specialty is heart and lung transplantations. And our focus is mainly towards lung transplantation. 80% of the transplant is all lung transplants. So we've done quite a bit of first surgeries in India. I'm just showing you a very brief video of a transplant recipient after the lungs being implanted. This is how it looks. So we do a completely open the chest up, clamshell incision is what we generally call it as, and then implant the lungs. This is again a patient who's about to receive a combined heart lung transplant. This is just a harvested organ, and this is the recipient. like within 7 days, she's extubated, and both the lungs and the heart are working fantastically well. So transplant is actually very unforgiving field. There's no zone of errors, and it involves a team of critical care people, pulmonologists and cardiologists together, and with a lot of paramedical staff, physiotherapists, etc., etc. So it's a huge effort. The surgical part is just only 20% of it, and even a simple mistake can turn it, like very painful, and the outcome could be very devastating. So like this kind of outcomes is quite gratifying and inspiring for ourselves. And this is again how a lung looks. I mean, this is pre-op. Once you open it up, this is how a lung looks. This is a case of ILD with severe cystic lesions on the right side as well. The left lung is completely fibrotic. So, and after some time, this is the same patient. He goes on to get a good pair of lungs. And this is how it looks. Because we are playful there, showing cattle show there. And this was a very classical textbook patient we had. It was a personal favorite for me and Dr. Sharanya. She was there with us for 9 years. So what typically happens is, once a diagnosis is made as end-stage lung disease, from then on, it takes about, like, the average by literature, they say 6 to 12 months for the transplant. So she stayed with us for 9 months. That's the actual period required to prime them towards the therapy, to optimize them towards the therapy, walk them through it, and then list them, and then wait for the right organ. If you give them a good organ, the outcomes are always good. Once the organ becomes borderline, the recipient gets sicker, then the outcomes are a little more devastating. So this lady, she got a transplant done, 19-year-old lungs was transplanted into her. And then the recovery is phenomenal because she was optimized very well pre-op. This is the day 4 recovery, and the best part is, on day 5, she could bring up almost all the 3 balls, which not even a CLD patient would do it. So this was very gratifying for us, and she put back to Ahmedabad. She's still doing well. She's almost post 2 years lung transplant. And our daughter is a doctor from Ahmedabad. She's a medical student. So this is again, this is the first kind of procedure in India where me and Sharanya, we did this. Post-transplantation lung transplant is right heart ventricular failure. So we put on a percutaneous right heart support, which is called as a protectio. So this was the implantation done. So the camera goes percutaneous through the IJV into the heart, goes into the ventricle and comes upwards towards the pulmonary artery. So it reduces the workload on the right heart and helps in recovery. This is again the video saying implantation of protectio, showing the case of the camera inside, it's covered up into the pulmonary artery. And this is our team. Dr. Rahul has already mentioned about our team. Dr. Apar Jindal heads the entire Institute of Thoracic Sciences, and we come under it. So I lead the cardiac thoracic division, and Dr. Kumar is the thoracic division, Dr. Sharma is the anesthesia division, and Dr. Associate Consultants are there, Dr. Amol and the pulmonologist, thoracic division is also there. So I just made it as a small introductory thing. So I am not going into details. So any questions, anything to be asked, we can have a discussion later.
Negi, you can come here, Dr. Prem. So we have finished at 10:06, 10:07. We have about 15 minutes for interaction. I request all of you to ask your questions, keep them short, and I would also request, yes, Dr. Luthri, I am coming to you, but just a minute. First, let the moderators set the context. For the first talk, Dr. Mangla sir, some beautiful cases were shown by Dr. Rahul and reminded me of my MD classes which I used to have with Dr. Suri. And we used to go all the way to Maruri TB Hospital, sir, now called the NITRT, for some very, very bad cases which we had to face in the exam. Followed out cavities, pneumothorax, destroyed lungs, which Ravindra gets all the time, and he said that they get to operate only on very bad lungs. So, sir, your perspective on the kind of work that Rahul is doing in MaxSmart, coming from a wonderful pulmonologist of your stature, what do you think? I'm sure we, as all the delegates, wish them very good luck and let them be successful. But your take on the cases and your words of wisdom about what we saw.
I think wonderful cases. The messages that whatever you see with the eyes it may not be always correct. Like no, मेरे को इसकी शक्ल देख के लगता है ये तो TB है, इसको ATT दे दो. There was a time when on a fever not responding to the diagnosis microbiologically, prove that it is resistant TB, rifampicin resistant TB, do cultures, do sensitivity tests later, or do PCR tests. Because if it is a resistant TB and you are missing time, you are not supposed to treat that TB. It will be treated in the government institutions because those drugs are not available. And whenever you think that this is TB, it may not be. It may be malignancy, it may be fungus. Just go in the background of the patient, what it really is. I think with the availability of the CT guided biopsies or the radial EBUS, you are able to approach the peripheral nodule. It is not that simple. If patient is not responding and you have given all the antibiotics, what do? You go for a bronchoscopy, you go for a biopsy, you will have to have a diagnosis. If there is a background of HIV, it may be NTM or it may be other infections depending on the CD4 counts. So Dr. Rahul could prove that this is mucor, he could treat, it really saved life. Otherwise this patient would have died. So missing a malignancy, and once you think that you have treated a patient and if he gets well, it is yours. If he doesn't get well, then somebody else will do it. Will take the blame or credit. If you have seen the patient, you are totally responsible. Your prescription is there, you have to make a diagnosis. And if it is resistant TB, in all cases of tuberculosis, whether it is lymph node TB, pulmonary TB, you have to do gene expert, you have to prove this is rifampicin resistant, straight away send him to the government hospital because those drugs will be available. You have no business to treat him with some other drugs when the better drugs are available. The regimen of PPL-M which has come is a wonderful regimen to treat MDR TB, except for certain exceptions where this regimen is not to be given. Wonderful job. I think they are doing everything. They are doing cryobiopsies, they are doing EBUS, routine bronchoscopy, EBUS, putting stents. Like the other case, there was a gap there. So that was the cause of cough. Look at the X-ray, not knee jerk. I think go through the soft tissue, body cage, mediastinum, angles, comparing space by space, then you will not miss it. Thank you.
For the second talk, although not many slides were shown, but I think with the open chest, I was totally aghast actually, and I asked Dewan कि यार ऐसे ही होता है क्या? इसने कहा हाँ यार ऐसे ही होता है, and then I asked him कि यार तूने किया है क्या कभी? इसने मैं सिर्फ destroyed lung ठीक करता हूँ, मैं ये वाला काम नहीं करता हूँ. And I asked him कि हो कहाँ रहा है? दिल्ली में कहाँ पे हो रहा है? So he gave me some places. Medanta is one place which is doing it, and the problem is with the failure rate. So we'll see at the end of 1 year, 2 years, Rahul. We'll get back to the team, and we would like to have a meeting again, and like to see the success rate. Dr. Dewan's viewpoint on the second topic.
Thank you so much, Sushil. Thank you. Actually, lung transplantation excites me a lot because end-stage lung disease is a problem in India, and all of us know there must be at least, I can easily say 50,000 to 1 lakh patients who are in end-stage lung disease who require lung transplantation. And despite the best intentions, best cardiac surgeons, best corporate hospitals intending to develop a lung transplantation program, our own India's lung transplantation program is insignificant as compared to that in the US, Europe, Australia, New Zealand and Japan. And we have a number of cases. Primary indications existing of interstitial lung disease, coronary COPD, and of course cystic fibrosis, which is not very common in India. But in India we have a huge load of post-tubercular bilateral destroyed lungs, which are normally not an indication for lung transplantation, but with the present day investment, emotional investment, psychological investment and financial investment that these guys are doing, it may also be a possibility because it is not an absolute contradiction. So I am very happy to know that Dr. Prem has shifted because whatever is my knowledge, and I am in National Institute of TB and Respiratory Diseases, I have been several times given a go-ahead to develop lung transplantation in India in this country. Dr. Ranjan Vadva was my own director. He also said that he will talk to Ministry of Health and get whatever funding available. But lung transplantation is much more complex because it involves many specialties, including a very dedicated pulmonologist like Rahul Sharma, pathologists who can do biopsies, regular bronchoscopies, psychologists, neurologists to differentiate that it is a brain dead patient. That's why lung transplantation. And secondly, add to that, that even if we do a successful lung transplantation in the Indian context, with a lot of infection all around us and a lot of overcrowding, the long-term survivors are still not huge. But all of them, whoever are engaged, are doing a lot of good work trying to establish this specialty. So with this,
Before I submit to all of you, there are two questions that I want to ask this erudite panel. And I was discussing with Dr. Rahul Bani, happened to be in my chamber, and it was a privilege and honor. I want to know, especially from Dr. Prem, why the program is so successful in Tamil Nadu and Telangana, and why we are so much lagging behind in North India, that when we heard of a lung transplant, it suddenly looks, lung transplant ho gaya. When it should actually look routine, like a kidney transplant or a liver transplant. From your own experience, and you have spent some time here and you have had your career in Madras Medical College, how long do you think lung transplants are going to become routine in North India?
So thank you, sir. So the perspective is the south of India has more of lung transplant program going on. The reason is the acts of donation. So the awareness is very widespread. The NGOs have driven it into the system. So you go to a government hospital, somebody's relative is dead. You see like old lady climbing up 5 floors, coming up and saying, where is the place to contact for a donation? So that is the level of awareness there. Tamil Nadu like leads the thing. About last year, 285 donors in 365 days. That is like roughly about 1 in like 2 days kind of thing. So it's phenomenal. And also sometimes there are 3 donors in a single day. So the level of donation is very much up. So the organs available are huge, and for lungs especially. So if you're going to pick up a heart, you see 3 good hearts, you can pick up 1 or 2. But if you go to 10 donors, the retrieval rate in US is only 15%. So over 10 lungs, you can pick 1 or 2 lungs. That's all it is. So you need to have a very well optimized lung. So that is why lung availability is a problem. So you get 10 donors, you can make use of it like one president will be very good. So that is the problem. There's not much of donation happening in the north of India, but I think things are changing now. Gujarat has picked up very well, Maharashtra is doing very well. So very slowly, probably, we're going to see like better things happening. So right now, the strategy of the program is also to list our patients with donations are happening. So that's why we're encouraging Nanavati, Mumbai also. So that we go towards the side of donation. And one more thing is we are advanced in the technologies, the boxes that is available now. It does not need to be storing the lungs at -4, -10. It does be like 4 and 10 days and upwards. So the thermal regulation is much better. So the ischemia time can be much longer. Outcomes can be better. And also like the opening of the clamshell. Now we are moving towards robotic. So in future, we're not in a very distant future, in a very near future, we'll be doing robotic transplants. Already it has been done outside the Western world. So those things are going to come up and improve. And when there is a tremendous need for the situation, I think in general, I think the optimization of the neurosurgery team will come in to provide better donors in North India. I think probably in another 6 months to 1 year, I think this scenario should be better.
Thank you, Dr. Red. Please stay here. Have you guys been able to do lung transplant in MaxSmart as yet or not?
We just onboarded, like we just onboarded ourselves from the mid-week of April. So it's just our first month and thing. And so we have listed our patients. Our patients are being listed in Max Nana in Mumbai for now. So their licenses are all set to go and we're ready for transplants. We recently had a call to Pune. So anytime sooner we'll be operating and getting on to the first lung transplant for Max. And in Delhi we are yet to get the license and things. So probably in a couple of months I think we should be set.
So I want to. Dewan, एक मिनट. सवाल एक मिनट.
जरूरी इशू ये है. You see, I am actually the Government of India's chairman of the Delhi committee to give license to any organization or institute to start lung transplant. So our thinking so far, because I want this audience to know that all the Institute of Medical Sciences, when they applied for lung transplantation, we immediately gave. They had all the facilities. But in corporate hospitals, when we see these facilities, we look, you have a cardiac surgeon, you have a thoracic surgeon, you have all the equipment available, including ECMO, everything which is available. But we will give you a lung transplantation certificate if and only if your thoracic surgeon, cardiac surgeon, and the pulmonologist, both of them have a training specific to transplantation for at least 3 months. So please, that is one thing that I wanted to make clear.
Okay, my question was that only. Do you require a DCGI approval on a case-to-case basis for every single case of lung transplant that you are considering? You can, any one of you can answer.
DCGI approval is not required for this. It is the NATO who is actually informing us that this lung is available.
NATO is about the availability of the organ.
Yes.
But do you require permission, which Ravindra is mentioning?
If you got the license, I think
License which is there valid for 5 years, which has to be renewed again after 5 years. Not for everything. Not for everything.
So you don't have to go for
For an
a case to
individual
case.
case, we go and see in a committee that
Right.
the infrastructure and the training and other things are available. If it is given, we give a certificate and then we renew it.
Right.
As I told you that we were more liberal for government institutions, but for corporate institutions we included this thing that like Dr. Prem, there has to be a surgeon, not just a cardiac surgeon available. A surgeon trained specifically for
At
lung
least for 3 months. Right. Dr. Ashok Chakravarti sir has a question.
Dr. Ramesh and the team, we're very privileged to have your team in Saket, which is in South Delhi. And we are lucky once again. My being pediatrician, I have a question. Do you undertake pediatric pulmonology cases also? Because kids are very naughty. They keep on putting things into the mouth, and once in a while they aspirate into the air, or the foreign body in the lungs. So, do you undertake, and what's the youngest case you have ever seen? For the large interest of my colleagues.
9 months is the earliest child in which we take out foreign body.
So you are doing pediatric cases also, and you are doing holistic pulmonary care. There was actually talk about the holistic 24 hours care. I requested Dr. Rahul, we can spend that time in discussion, and maybe I will play a song for all of you after having introduced their wonderful team to all of you. That is the apt song that should be played after this. Dr. Saurabh Bansal all the way. First of all, congratulations to Dr. Saurabh. I was honored to visit his center, wonderful center in Oscars. Wonderful center.
Sir, I have a very simple and straight question, being a surgeon. When a deceased person has decided that they are going to donate the lungs, you have harvested the lung. Since there are a lot of prerequisites for lung transplant, how do you decide that this lung will go to which patient on the donor list? Once you have harvested the lungs from a deceased, what are the prerequisites that this lung, once you have retrieved, will go to which donor? Which donor?
Which recipient?
Which recipient, sorry.
That is already being decided. Once the list is published.
You said that the size of the lung is very important, right?
Yes, sir.
So how you decide among the list that, okay, this lung, my lungs might not suit a small person?
That we are roughly the height of the patient, and then the chest X-ray, then the volumetric CT analysis, all these things. We do a pre-operative or a pre-arrival thing. Yes.
The other important thing is, if the lung is bigger than the size of the recipient, we can always remove the middle layer. Fit it.
Size reduction.
Anatomy reduction is possible.
There is a center in Japan which is doing for pediatric patients the live donor transplant. Live donor. Because the parents give their own lobe, and one lobe is equivalent to a lung in the child.
It is not, but it is not allowed in India.
It is not being done in India. It is
No,
done
not being done, not allowed in India.
allowed after now. No. Not yet allowed.
Not yet allowed.
But live donor transplant for lung for pediatric patients is a possibility, and a center in Japan has published more than 300-400 cases. They are doing it. They give a lobe only, lobe take from a parent, and that lobe is transplanted to a child who is suffering from end-stage lung disease, and it is quite good.
My darling, live donor transplant is not allowed in
Not
India.
allowed in India, and for lung and heart it is not allowed.
Yes.
It's only allowed for kidney and liver.
Yes, Dr. Sarat.
Just want to bring up a point. In 1998, we had the first pediatric liver transplant happening at Apollo Hospital. That's the first liver transplant ever happened in India. It started with pediatrics and later moved to adults. So it's about 28 years now, almost. 1998, yeah, 28 years. Yeah. So the point is, when pediatric liver transplant can happen and other transplants can happen, I think all of us as a community, I'm not part of your field, but we should all encourage lung transplant, adult or pediatric. Today you're starting with adult, tomorrow we'll start with pediatric, maybe. But I think we should all encourage that. But he made a point that for pediatric lung transplant and something, there's no sanction available.
No, there is no sanction for live donors.
Because today,
But if a child suppose dies in a medical hospital or a college who has a brain dead and is declared to be brain dead,
there's a point here. Because in South India, Dr. Leela does all pediatric liver transplants with cadavers.
the liver is different.
No, and it works well. He's built up a whole transplant institute. But in North, it's live living related.
For lung and heart, as of now,
Okay, Sarat, no. We have to understand one thing. Let's not digress from what we are discussing. The live lung donation is not allowed in India, even if it is a loan. Please understand that. And that is where we are. Dr. Ravindra is in the committee. He is the chairman of the Delhi committee. I think he is one person who can at least advocate for a lobe to be donated to save the life of the child. So sir, it's up to you.
You see, this is only the Parliament of India which changes the laws. We have a 1994 Organ Transplantation Act as of now, so we cannot change beyond that. As a doctor or just a chairman of the committee, I don't have the competence or the authority or the power to change the law. As of now.
You will be called for opinion. Suggestion. Right, Dr. Luthria sir has a question.
My question will be solved over the laptop. So I have to sit personally with Dr. Rahul.
All right, sir. On the laptop, Dr. Rahul. You understand now why we are discussing this, and that presentation which you have sacrificed, it's worth it, because you might get some cases because of that. Dr. Tulsi sir.
Thank you, Doctor. That was a wonderful talk. Talk us a little about the future of lung transplant.
The future is first thing, like I said, live donor is one thing that we are expecting to come into India. The second thing is about the incision. We're going to come down on the level of incision.
I'm referring to the EVLP.
EVLP we had tried twice. We have done twice in Hyderabad Kmes Hospital. The main obstacle is the cost. It's about cost about like.
What is EVLP?
External lung population. Basically, you get the lung and directly
For lung preservation. So this is expanded, the timing, not only timing, but the donor of this thing. So even marginally, which were not accepted, are accepted today. Apart from this, what about the total artificial lung? TAL.
Yeah, it's still on a very rudimentary stage. Still on academic levels. It's not very difficult to get it practically implemented.
Any new immunosuppressions today? I'm referring to the MAB.
So I think the immunosuppression remains the same. It is MMF, azathioprine.
What about the acute rejections? Apart from giving high dose of corticosteroids,
We need to go back to steroids for this.
apart from that, any role of the recent MAB? You see, for a few days, to prevent graft rejection.
No map has been approved, I guess.
There is one map which is approved.
Dr. Saranya,
Should for antibody-mediated rejection, we are using like
Right.
rituximab, bortezomib.
Absolutely. There you are.
he is the man, sir. He's the
Dr.
man.
Prem, actually, Dr. Prem has made a very important observation that traditionally speaking, because lungs are done bilateral lung transplant. So either it's a bilateral thoracotomy or a costo-transverse incision, which is absolutely huge. What he is saying is that we are now exploring into the area of robotic incision and doing bilateral lung transplant.
Absolutely.
Can you please elaborate on this? Because how long will it take?
So let me say, worldwide it is 50% you're doing by minimal access surgery, just 12% by robotics. Why so? Is it because robotics would take a longer time to do and you need an expertise and more anesthesia here?
So like already you said the answers. So one is more expertise. So once you get into the access of robotic system, we need number of volume of surgeries to be committed before you actually do a transplant. That is one. And like you said, time consuming. So the expertise, even though it's the finest level, the HCA time you do not want to compromise. Open is straightforward. You go bang in 45 minutes of transplant time, on the other side 40 minutes of transplantation time. That's about 2 hours. Preparation is about 2 hours, so 4 5 hours. So the total HCA time doesn't exist 6 hours or 7 hours. That's the ideal time we're looking at. But robotics will be little more and more expensive.
So why I was talking about the total artificial lung was in relation to ECMO and mechanical ventilation, which would not address the basic problem of sepsis. See, patients would die of septic shock, so herein lies the fact that probably a total lung transplant, this thing is needed. Thank you, sir.
Thank you, sir.
I'm Dr. Anand Kalra, and my question is more like a breather, not exhaustive like him. There was a Dr. Rahul. You showed an interesting case that you tapped through trachea, and the pericarditis is many times ongoing thing. So how many times you will be going through trachea, and why not through esophagus, which is also so close, and make a shunt or fistula like, because we do it so for hydrocephalus.
Talking about pericardial effusion.
I have pericardial effusion case.
Pericardial effusion we are doing very rarely because our cardiologists put their
Hypothetically, I am saying, suppose there is posterior pericarditis, pericardial effusion, and esophagus is so close. So can you do it through esophagus and make it shunt?
I think the gastro people in the US, they can also try through esophagus. We had this patient with our specialty in ICU, so because we have this facility, so we tried this and thankfully we successfully.
Thank you, sir.
We had a wonderful discussion, and since now we know the entire team, the lung transplant team of Max Smart, Dr. Rahul, Dr. Prem, Anand, John, and Dr. Sharan. I'm sorry, keep forgetting your name. I have a beautiful song for you.
See, because transplant has excited you a lot, and I will still tell that transplant, lung transplant, because it started in 1980s with the introduction of cyclosporine with reasonably successful results, and in the Western world, almost 10-year survivals are in the range of 90%, and we are not replicating in India, where in my own estimate, it must be out of 1 million people requiring lung transplant. That's the only right.
अब गाना सुन ले आप सब लोगों के लिए